At the end of part 2, I suggested to you that a development response to non-communicable disease would involve addressing the bottom of a triangle of responses. The bottom of the triangle would address more the broader structural drivers of non-communicable disease and would give attention to the broader political economy of non-communicable disease. In part 3, I'm going to talk in a bit more detail about policy responses, and I'm going to do that by focusing first on state-level responses and then on responses at the level of the household and individual. At the state level, we might talk about issues of governance and political will and the relationship with agri-food business. The level of the household, I'll be talking about social protection measures and also responses from the health system. So first of all, let's think about state-level responses and in the development sector. Now, there are a number of overarching points that I want to start with here. First of all, in thinking about state-level responses, I want to conceptualize the food health system, as one might call it, as a connected system. In other words, issues of food safety and food supply chains and whether these are trustworthy are all questions that involve understanding a food system and a health system together. And the kinds of questions that this might generate would be questions like, how can the quality of affordable processed food be made available to people living in urban areas? Questions about how the state should engage with the private sector, questions about regulation, questions about whether one should have new forms of regulation. In addition, there are a set of questions about subsidies of food and whether agricultural subsidies to date have been more supportive, for example, the production of refined carbohydrates rather than, for example, fresh fruit and vegetables. Overall, this relates in part to a broader set of literature around healthy cities, particularly literature in environment and geography, but I'm going to engage less with those debates and try and keep this discussion focused more at the level of development and non-communicable disease. So let's first think about the relationship between business and non-communicable diseases, in particular the food industry. Now, there are a number of baseline observations one can make about the evolution of food markets in middle-income countries in particular, and it's evident that this kind of evolution is happening on the lines of a high-income country model. This means increased consumption and availability of processed foods and also increased consumption of food outside the home rather than people always preparing food at home. So overall, these food consumption patterns are rapidly aligning with those in high-income countries. And it's worthwhile, therefore, focusing on the kinds of incentives that exist for food businesses to actually also develop, manufacture and market healthier foods in such contexts. So if we start thinking about policy responses, there is in fact evidence that governments in middle-income countries in particular are looking to govern food markets specifically in terms of impacts on non-communicable disease. And in brief, there's several approaches one can isolate. For example, a broad set of approaches that one might call facilitating consumer choice, and this would lead to policy and regulatory measures around, for example, labelling requirements for processed food, legislation that places limits on and regulates the kinds of claims that companies can make about the nutritional value of the foods that are marketed. There's also the whole issue of countries producing very clear dietary guidelines for the population, and allied to this, conducting education campaigns to promote healthy food. The other broad set of policy responses involves what one might call the restriction of marketing of foods that are deemed to be unhealthy. And here we might see regulations around the compositional standards of particular foods, for example, the amount of salt or saturated fats or unhealthy fats that foods contain. There's also legislation that can be brought in around the kinds of advertising and marketing that happens of unhealthy foods, and in this regard there have been measures in particular to control advertising directed at young children. And then there's a third set of measures that can come under this category of restricted marketing, and these are what one might call pricing controls, in particular taxation of foods that are deemed unhealthy. So really, in summary, if one thinks about this relationship between the food industry and the state, there is evidence that middle-income countries in particular have been responding to concern about non-communicable disease and been taking more concerted action to try and introduce some of these regulations. However, the responses differ across middle-income countries, both in terms of the specific measures applied, but also the extent to which these regulatory measures have been enforced by the state in a co-regulatory approach with industry or simply as legislation. So we have some examples. In South Africa, the government has introduced legislation to control salt content of foods. And then we also have a more recent example of a measure that was introduced in Mexico in 2013, and this falls into that category of pricing controls and involved in particular what has been called a sin tax. In other words, taxing substances that are unhealthy. In this case, it was carbonated soft drinks. And indeed, the Lancet Global Health Commission, in fact, advocates for such sin taxes as an important part of a policy response against non-communicable disease. It's difficult at this stage to make a definitive judgment as to the effect that sin taxes might have on populations. And from a development perspective, there is some concern that these kinds of taxes do not, in fact, end up restricting the industry, but rather increasing the cost of food, in particular for poor people. So that's a measure that I would argue requires a lot more investigation in terms of possible unintended consequences for health. I'm now going to move to talk about a set of policy responses and issues that one might put under a broader title of governance of non-communicable disease. And the kinds of questions that arise here are really around the fiscal and health-related costs of non-communicable disease burden and how one might make an argument, a social and economic rationale for government intervention in non-communicable disease. And this really points to the need for more evidence about cost-effectiveness of non-communicable disease interventions weighed against economic analyses of current and future burdens, both to health and social care systems. And this is a complicated area in health economics and beyond the scope of this lecture. Indeed, it's a somewhat contested area and therefore important to think about how these arguments can best be made to policy makers. And indeed, there's a second set of questions that arises then about how government will in fact generate revenue for funding responses to the non-communicable disease burden. And this is really where this interest has come, in particular around additional forms of taxation, particularly on unhealthy products, as a source of generating revenue. And then there are a third set of debates that one might call governance debates, that are debates about the extent to which government should be engaging proactively with the private sector. And there are several private sector interests that come to play here, both within the pharmaceutical industry but also the food and agricultural industries. And some people have advocated for public-private partnerships to ensure effective participation and involvement of the private sector also in the response to non-communicable disease. And indeed also the role of civil society organisations in terms of generating and amassing evidence to advocate for interventions and also to monitor the progress of government interventions. So now I'm going to talk in fact about the example of Brazil, where there is an evidence of this alliance building across government, private sector and also civil society. And indeed what becomes important there is the necessity to articulate a common and coordinated message about the importance of responding to the non-communicable disease burden and to involve multiple stakeholders across these various sectors, including civil society and the media. So if we look at the Brazilian example, there's evidence of high-level government commitment to actually address this issue both within the health sector and the unified health system, but also in terms of regulating the private sector through measures such as mandatory food labelling, but also examples of these public-private partnerships with private sector, for example, with the pharmaceutical sector in the distribution of generic low-cost medicines to people with non-communicable disease. There's also evidence in the Brazil case of positive campaigning, for example, around exercise schemes, the distribution of nutrition information and other links with other health programs and food security interventions. I'm now going to move to the second set of potential policy responses, and this is at the level of the household and individual, and I'm going to talk about social protection and health systems responses. So the overarching issues here really pertain to the projected burden of non-communicable disease on the health system, particularly when one has limited human resources for health, and also how to plan for the cost and burden in terms of social care. And one of the questions is really how one might integrate health and social protection responses for non-communicable disease, particularly around incorporating measures for health prevention and promotion. In terms of thinking about social protection measures, there are a number of interesting initiatives, particularly around prevention and preventative social protection. And this involves looking more closely at preventative measures such as school feeding programs, and also the question of cash transfers to people to be able to address their illness, manage their illness, but also in a preventative way to encourage healthy eating. There's been an interest in these so-called conditional cash transfers, but also concern that these need to be implemented with care, again, so as not to have unintended consequences. There's also been a call to have closer integration of social protection systems and health insurance systems to ensure that people who have very minimal access to such insurance are not neglected. This really emphasises that individual needs and households need support from the state in order to balance the way responsibility for addressing disease is allocated. And here the chronic nature of these conditions is key, and this I'm going to bring up particularly now when I discuss some of the current health systems proposals for responding to non-communicable disease. In part 2, I briefly mentioned some of the more biomedical responses that have focused very much on the level of the individual and individual behavioural change, and this whole idea of individual self-management of illness has been picked up also in health systems proposals, where there's been a suggestion that in settings with low resources there really needs to be a move towards what has been called full patient self-management. And this has been proposed not only for non-communicable disease, but also for other chronic lifelong conditions, as they've been called. And the idea here is that an individual would take responsibility for behavioural change and various other disease managing strategies to reduce risk. And various proposals have been used here, some of them drawn from the HIV sector, but also from chronic illness programs in the global north. For example, the whole idea of expert patients, which originated in Borneo but has also been picked up in the national health system in the UK. In low and middle income settings, there's also a lot of interest in harnessing some of the new diagnostic and screening and monitoring technologies and trying to support low-cost use of these technologies to try and support disease self-management. Some countries have focused quite heavily on making cheap drugs accessible and scaling up drug distribution systems, and in some of the public health literature this is presented very much as the low-hanging fruit of health systems control of non-communicable disease. And linked to this is really the idea of having simple screening and management protocols, even measures that could be addressed by community health workers. Some countries have proposed basic packages of care for particular non-communicable conditions that would be covered by national health insurance. But there's also a lot of interest in involving community-based organisations to support disease self-management. And if we look briefly at the example of South Africa, you see some of these health systems ideas being implemented. In South Africa, there's recently been some political will to address the issue of non-communicable disease, and a lot of interest in learning from the experience of HIV and systems for the distribution of antiretroviral therapy, and also measures to support behavioural change and disease self-management, such as through disease clubs that also extend drug distribution into the community and thus reduce pressure on health facilities. So this whole idea of learning from other chronic illnesses such as HIV is very prevalent in the South African example. There's also a new national health insurance framework and a lot of interest in task shifting, as it's called, in other words, getting lower level healthcare workers to kind of address some of the work around supporting disease management. And this whole idea of community health workers and outreach teams into the communities disease to support drug adherence and behavioural change, and indeed also to lead screening and early detection programs. Some of this learning has come, in fact, from the Brazilian health system model where such outreach teams exist. I also mentioned the issue of mass drug distribution, and in Brazil there has been very much this relationship with the pharmaceutical industry to promote that. But in conclusion, I really want to link some of these policy questions to bigger debates in global health, and partly to suggest some caveats for the big move towards patient self-management. And these caveats really arise from this political economy perspective of non-communicable disease. Firstly, just to say that in the global health discourse, there's a lot of emphasis on scaling up initiatives such as disease self-management. In many of the low and middle income country contexts, the reality is that in the presence of weak health systems, people have probably been managing their own illnesses for some time. So on the one hand, there's a set of questions around how one addresses non-communicable disease in the context of a plural health economy and plural health markets where people are confronted with many options for disease self-management. So this really raises the question about the responsibility of the state, about the quality of state care, and how the state might start engaging in new kinds of partnership to support self-management, and questions also about how the state can regulate access to safe and trusted health knowledge and services in the face of informal markets for drugs. Overall, then, one has to keep some critical perspectives in mind when considering these different policy options. And in my final summary, I would like to return again to some of the authors, such as Stuckler and Katz, who have really warned against the other side of medicalizing the non-communicable disease response. In other words, asking questions about what kinds of interests are also promoted by this kind of medicalization. So what kinds of opportunities does this create, for example, for big pharmaceutical companies, and how can this be regulated? Secondly, I'd like to again return to Susan White's work, where she uses the example of Uganda and point out that in fact this category of non-communicable disease in this context, she argues, does not necessarily equate to how people experience these conditions in a context where chronicity is key, but actually there are minimal existing medical services for non-communicable disease. And indeed there are concerns about really putting a lot of responsibility on individuals for managing these diseases in the absence of a supportive health system. Indeed, White argues that it's difficult to identify people at disease risk in a context where there is no health provision, and that really it's the access to treatment that might shift how people can come to perceive these conditions. And she makes this bigger point that I've mentioned before, that one has to consider the kinds of socioeconomic determinants and the conditions of life that make it difficult for people to undergo changes to their behaviour if they live in contexts where such choices are not an option. And this is also really the difficulty with promoting self-management of non-communicable disease in a context where the social determinants of ill health have not been addressed.